Hello everyone. Welcome to Pharmd Guru. In this video, we are going to talk about drug dosing in the elderly and pediatric populations. We have already discussed dose determination in previous videos. A key point to note is that those dosage regimen designs we discussed are typically applicable for adult patients. However, there are two other special populations where these regimens might not be suitable: pediatrics and geriatrics. Special care must be taken while prescribing medications for these groups. Let's discuss why these precautions are necessary. First, we'll talk about pediatrics, and then we'll move on to geriatrics. Alright, let's quickly go through the classification of age groups. This table outlines the different stages of life and how we categorize them. Preterm newborns. These are babies born before 37 weeks of pregnancy. They are also known as premature infants. Neonates. These are babies from birth to 28 days old. This is referred to as the newborn phase. Infants. This group includes babies from 1 month to 12 months old. During this time, their bodies and organs grow rapidly. Young children. This includes children aged 1 to 5 years. This group covers toddlers and preschoolers. Older children. This group includes children aged 6 to 11 years. These are school-age children. Adolescents. Adolescents are aged 12 to 18 years. This is the teenage phase, where they undergo significant physical and hormonal changes. Young adults. This group includes individuals aged 19 to 40 years. This is referred to as early adulthood. Adults. Adults are aged 41 to 65 years. Elderly or geriatrics. This group includes individuals over 65 years of age. It is further divided into 3 categories. Young old, aged 65 to 75 years. These individuals are generally active and independent. Old, aged 75 to 85 years. This stage marks the beginning of more noticeable age-related changes. Old, aged 85 years and above. People in this group are often frail and require additional support. This classification is important because each age group has unique physiological characteristics that influence how they handle medications. As healthcare professionals, we must adjust drug dosing accordingly to ensure safety and effectiveness. I hope you get a brief idea about the different age groups and their classifications. Now for our topic, drug dosing in pediatrics. Here, pediatrics typically includes individuals from birth to 18 years of age. The categories are preterm newborns, neonates, infants, young children, older children, adolescents. Now, we're going to talk about drug dosing in pediatrics, specifically how the physiology of children differs from that of adults. First, gastric pH. A newborn's stomach is less acidic than an adult's, which changes how certain drugs are absorbed. For example, phenytoin, an anticonvulsant, can be absorbed differently in neonates because of their less acidic stomach. So, we need to account for these differences when prescribing medication. Next, gastric emptying time. Infants have slower gastric emptying compared to adults. This means that drugs will take longer to pass through their stomachs and get absorbed. So, drugs that require quick absorption, like antibiotics, may take longer to start working in children. Next, body composition. Children, especially infants, have a much higher percentage of water in their bodies, up to 75% compared to 60% in adults. This affects how drugs are distributed. Medications that dissolve in water, like digoxin, are distributed differently in infants, so we need to adjust their dosage accordingly. Next, protein binding. Infants have lower levels of plasma proteins, such as albumin, compared to adults. This means there's more of the drug in its active form because there's less protein to bind it. For example, drugs like sulfonamides can displace bilirubin from albumin, leading to a risk of brain damage, which we need to avoid. One of the most important factors is how the body metabolizes and eliminates drugs. The liver is still developing in infants. This means that drugs are metabolized more slowly. For instance, theophylline, used for asthma, stays in the system longer in neonates, and they require lower doses than adults. Kidneys are also immature in newborns, which affects how drugs are cleared from the body. A classic example is gentamicin, an antibiotic. In neonates, it's eliminated much slower because their kidneys aren't fully developed, so we need to adjust the dosing to avoid toxicity. Speaking of risks, Let's talk about the blood-brain barrier. In infants, it's not fully developed, so certain drugs can cross into the brain more easily. For example, morphine has a stronger effect on the central nervous system in babies than it does in adults because of this. That's why we need to be cautious with dosing these types of medications. Another key point is cardiovascular differences. Infants have faster heart rates, and their circulatory systems are still developing. This impacts how drugs are distributed in the body and how fast the drug reaches different organs and tissues. Finally, respiratory differences. Infants breathe faster than adults and have different lung capacities. So, when we're prescribing inhaled medications like salbutamol, we need to adjust the dosage based on their breathing patterns and lung development. So, we have to keep all these changes in mind while prescribing medications to pediatrics and adjust the dose based on the condition. Speaking about prescriptions, based on these physiological changes, we can clearly say that the calculation of doses for adults is completely different from pediatrics. So, how is the dose calculated for pediatrics? Well, in children, we calculate doses based on weight or body surface area, BSA. Let me give you a simple example. Imagine a scenario where you are the doctor and a pediatric patient was brought to you by his mother. He is diagnosed with an infection and you have to give treatment. Now, according to guidelines, amoxicillin is the drug of choice for this condition. But at what dose? Now, you have to calculate dose. So, you googled amoxicillin monograph and you downloaded it. A monograph has a lot of information about amoxicillin, but for us, we need to dose. So this is how the dose was given. This is the adult dose of amoxicillin. Plain and simple. But for child doses, this is how they usually give the instructions or information. This is a weight-based dose. 20 mg per kg per day. So let's calculate the pediatric dose. First, weight-based dosing. Suppose a child weighs 10 kg and the drug dose is 20 mg per kg per day. It's clearly given on drug dose that per 1 kg, 20 mg of drug should be given. Here, baby weight is 10 kg, so 10 into 20 is equal to 200 mg of pediatric dose should be given per day. It clearly says every 8 hours, so we need to give 3 times per day in divided doses. So, 200 divided by 3 is equal to 66.6 mg should be given morning, afternoon and evening. That's why these pediatric medications have droppers inside their medication with measuring scale, also called calibrated dropper. Now let's see pediatric dose calculation using BSA, body surface area. This is the scenario. We have to give a chemotherapeutic drug to the patient. So, drug, chemotherapy drug with an adult dose of 100 mg per square meter per day. Child's weight, 20 kg. Child's height, 100 centimeters. Calculation happens in 3 steps. Step 1. Calculate the child's BSA. We use the Mosteller formula for BSA. This is the formula, and this is the result. Approximately 0.75 square meter. Step 2. Adjust the dose based on BSA. We know adult dose, which is 100 mg square meter per day. So, this is the formula. Pediatric dose is equal to BSA into adult dose. We already calculated BSA in first step. After substituting the values, we get 75 mg per day. Step 3. Divide the dose if necessary. If the drug is administered twice daily, we can divide total dose with number of times per day, here twice daily, so divided by 2, which gives 37.5 mg 2 times per day. That's how we calculate pediatric doses. Let's talk about drug dosing in the elderly. An important topic because as people age, their bodies change, and those changes can affect how medicines work. Who are the elderly? Let's start by defining elderly. This isn't as straightforward as it might seem. Usually, we consider someone elderly if they're older than 65 years. However, many people in this group are active, healthy, and independent. At the same time, there's another group, the older elderly, which includes those over 85 years. They're often more frail and may have more health challenges. For convenience, we sometimes divide the elderly into 3 categories. The young old, ages 65 to 75, many in this group are still very active. The old, ages 75 to 85, they may start noticing more health changes. The old, Over 85, they often require more medical attention and support. What changes in the body as we age? As people age, the body doesn't work as efficiently as it used to. This is called a loss of homeostatic reserve, meaning the body has less ability to bounce back from stress or illness. But here's the thing, it doesn't happen in the same way for everyone. For example, one person might have kidney problems but a healthy heart. Another person might have a strong heart but slower digestion. This variability is why medication dosing in elderly patients must be carefully considered. Why is this important for medication? With aging, there are changes in how the body works that can directly affect medications. Kidneys. As we age, our kidneys slow down. This means they're not as good at clearing out waste, including drugs. For example, medications like digoxin, used for heart conditions, or gentamicin, an antibiotic, can build up in the body and cause side effects if the dose isn't adjusted. Liver. The liver is where many drugs are broken down. In older adults, this process can slow down, especially for drugs that rely on what's called phase I metabolism. Examples include drugs like diazepam, a sedative. Because the liver doesn't break them down as quickly, these drugs can stay in the body longer and cause drowsiness or confusion. Heart and lungs. With age, heart function and breathing capacity decrease. This can impact how quickly drugs reach the organs they need to affect. Cognitive function. Some elderly patients may have memory problems or trouble understanding instructions. For instance, if a patient is supposed to take 3 different pills at different times of the day, they might forget a dose or mix up the schedule. Multiple medications. Polypharmacy. Many elderly patients take several medications for different conditions like high blood pressure, diabetes, or arthritis. This increases the risk of drug interactions, where one medicine affects how another works, or even side effects. For example, taking a blood thinner like warfarin with certain antibiotics can increase the risk of bleeding. Why do the elderly seem more sensitive to drugs? In older adults, even small doses of some drugs can have a stronger effect. Why? Because of changes in how the body reacts to medications, pharmacodynamics, and how the body processes them, pharmacokinetics. Here's an example. Sedatives like benzodiazepines, used for anxiety or sleep, might cause extreme drowsiness or even confusion in elderly patients because their brains are more sensitive to the drug. How do we adjust medications for the elderly? So, how do we ensure medications are safe and effective for older adults? Here are some strategies. Start low and go slow. This means starting with a low dose of the drug and increasing it slowly if needed. For example, if an elderly patient needs a painkiller like morphine, we would begin with a smaller dose than we would for a younger adult. Check kidney and liver function. Before prescribing certain medications, doctors may run tests to see how well the kidneys and liver are working. For instance, if an older patient has reduced kidney function, the dose of antibiotics like amoxicillin might need to be reduced. Simplify the dosing schedule. To make it easier for patients to remember, we try to limit the number of pills and times they need to take them. Instead of taking a medication 3 times a day, we might switch to a once-a-day version if available. Review all medications regularly. Doctors and pharmacists should check the patient's full medication list to avoid unnecessary drugs or dangerous interactions. Examples of common adjustments. For a drug like metformin, used for diabetes, which is cleared by the kidneys, we might lower the dose if kidney function has declined. For a blood pressure medication like lisinopril, we'd monitor for dizziness or fainting, which can happen more easily in older adults. In summary, when treating elderly patients, it's not just about their age, it's about how their body functions. The changes in their kidneys, liver, heart, and even brain mean we have to be cautious with drug doses and monitor them closely. Remember, the goal is not just to treat their condition, but to do so safely and effectively. Alright, so that's pretty much how we adjust drug dosing for pediatric and elderly patients. Now, let's talk about another special group, drug dosing in obesity patients. Here we'll be discussing obesity and drug dosing, and how obesity affects the way drugs are processed in the body. Obesity can significantly influence how we prescribe and manage medications. Let's dive in. So, what is obesity? First, let's define obesity. Obesity is a condition where a person has an excess accumulation of body fat. It's commonly assessed using the body mass index, or BMI, which is calculated using this formula. Alternatively, for those using pounds and inches, this formula is used. Here's a quick breakdown of BMI categories. For example, a person who weighs 80 kilograms and is 1.7 meters tall would have a BMI of. This is the formula. So weight is equal to 80 kilograms and height is equal to 1.7 meters and add square. We get 27.68. So, this places them in the overweight category. It's worth noting that BMI has limitations. For example, athletes with high muscle mass may have a high BMI but not be obese. Other measures like waist circumference or waist-to-hip ratios can be used for better accuracy. Why is obesity important in drug dosing? Now, why does obesity matter in drug dosing? Obesity can alter the pharmacokinetics of drugs, meaning the way drugs move through the body. This includes changes in absorption, distribution, metabolism, excretion. These changes make it necessary to adjust drug dosages in obese patients to avoid overdosing or underdosing. Let's look at each factor in detail, starting with absorption. Let's see how obesity can affect the pharmacokinetics of drug. Absorption. Absorption is how drugs enter the bloodstream. In general, obesity doesn't significantly affect drug absorption. However, delayed gastric emptying or altered gut motility in some obese patients might slightly influence it. For example, metformin's absorption is usually consistent in obese and non-obese patients. So, absorption isn't the primary concern in obesity. Distribution. Now, distribution. This is where things get interesting. Once absorbed, a drug is distributed throughout the body. Obesity changes this distribution depending on whether the drug is lipophilic, fat-loving or hydrophilic, water-loving. Lipophilic, fat-loving, these drugs accumulate in fat tissue, increasing their volume of distribution, VD, and prolonging their half-life. Example: diazepam, a lipophilic drug, stays in the body longer in obese individuals. Hydrophilic, water-loving, these drugs stay in water compartments, which are reduced in obese patients. This decreases their VD, meaning they might need lower doses. Example: gentamicin, a hydrophilic drug, requires careful dose adjustments in obesity. Metabolism. Next is metabolism, which primarily occurs in the liver. Obesity can lead to fatty liver disease, also known as hepatic steatosis, which impairs the liver's ability to metabolize drugs. Phase 1 metabolism, oxidation, reduction, hydrolysis, tends to slow down in obese patients. For example, midazolam's clearance might be reduced, requiring dose adjustments. Phase 2 metabolism, conjugation processes like glucuronidation, is generally less affected, so drugs like lorgipam may not need significant changes. Excretion. Finally, excretion. The kidneys play a key role in eliminating drugs from the body. In obesity, initially, increased renal blood flow and glomerular filtration may enhance drug clearance. Over time, chronic kidney disease due to prolonged obesity can reduce kidney function, impairing drug elimination. For example, aminoglycosides like gentamicin rely on renal excretion. Their dosages must be carefully adjusted in obese patients to avoid toxicity. Let's discuss clinical implications. To manage these changes, we often use adjusted body weight, ABW, or ideal body weight, IBW, for dosing calculations instead of actual body weight. Here are some formulas we use. Ideal body weight, IBW. For males, it is 50 kilograms, plus 2.3 kilograms for each inch over 5 feet. For females, it is 45.5 kilograms plus 2.3 kilograms for each inch over 5 feet. This is the formula we use to calculate adjusted body weight, ABW. Let's look at an example for better understanding. Let's calculate the ABW for a male who weighs 100 kilograms and is 6 feet tall. So, we get weight is equal to 100 kilograms and height is equal to 6 feet, which can also written as 5 feet 12 inches. So, IBW is equal to 50 plus 2.3 times 12. Here the patient is 12 inches over 5 feet. The final answer is 77.6 kilograms. Now we know IBW, which is 77.6 kilograms. Now substitute this IBW in adjusted body weight, ABW. We get 86.56 kilograms. We'd use this ABW for dosing drugs like aminoglycosides to prevent overdosing. In summary, Obesity impacts drug absorption, distribution, metabolism, and excretion, making precise dosing critical. Always consider the pharmacokinetics of the drug, use adjusted body weight formulas, and monitor the patient closely. Let's look at a case study. We need to calculate dose of gentamicin. These are patient details. Weight, 110 kilograms. Height, 5 feet 6 inches. Drug, gentamicin. And she is a female. Here is a step-by-step calculation. Because our patient is female, we use this female IBW formula. Her height is 5 feet 6 inches. So, she is 6 inches over 5 feet. So, after applying IBW for females, we get 45.5 kilograms plus 2.3 into, she is 6 inches above 5 feet, so 2.3 into 6, which gives 59.3 kilograms. According to gentamicin literature, dose of gentamicin is 1 milligram per kg. Here, patient's actual weight is 110 kilograms and IBW is 59.3 kilograms. Here, we have to take IBW, not actual weight, which is 59.3 kilograms. So, we get 1 into 59.3 is equal to 59.3 milligrams. That's how we calculate dosing for obese patient.